now. Good afternoon, Miss Barami, and good afternoon, Miss Nicholls. Can you hear me?
I can do, my lord, thank you.
Good.
Good
Now,
afternoon.
let's hope that Miss Barami can hear you and you can hear her. I'm going to hand over to her now. Miss Barami?
Thank you, my lord. Good afternoon, Miss Nicholls.
Good afternoon.
Now, you have provided a statement to the inquiry. For the record, the statement reference number is SCI WT 0367501. I want to reiterate that everything in your statement will be considered as part of our investigations alongside your oral evidence today.
Thank you.
Thank you. Could you tell us briefly about your background and about the College of Paramedics?
Certainly. So I'm a paramedic myself, still registered with the Health and Care Professions Council. I've spent most of my working career within an ambulance service in England, and I progressed my way to becoming the Director of Clinical Quality and Improvement with an English ambulance service up until the end of 2019, where I then joined the College of Paramedics, which is our professional body. And I've been involved with the college for many years as a volunteer. And the College of Paramedics, being the only professional body in the UK for paramedics, is very much supportive of paramedics in diversification of their careers and development, of lobbying government and arm's length bodies to support paramedic development, to support the pre-registration and post-registration curriculum for education standards, to undertake research and support policy development in that area, and provide legal support for paramedics who may come under fitness to practice proceedings through their regulator, the Health and Care Professions Council.
Thank you. Now, we've heard from some organisations that their work and activities didn't seem to have been taken into account by government guidance. I understand from your statement that that's also the view of the college. Please, could you firstly give us some examples of situations your members experienced which weren't covered by the guidance? And then I want to ask you about IPC cell guidance after that.
Certainly. So I think that the major thing from a college perspective was about the environment that paramedics work, and we're talking particularly about the ambulance sector in this case predominantly, although we do represent members who don't work in the ambulance sector. But the ambulance sector work is based on undifferentiated care, which means 999 calls, predominantly paramedics and ambulance clinicians will go to the 999 call wherever that may be. The patient is normally undiagnosed at that stage in whatever their emergency or urgent care need is not really known to the crew until they arrive on scene and determine that for themselves. So there is a case of paramedics and ambulance clinicians going to the call itself, wherever that may be, and not knowing what they're going to. And where COVID is concerned, that was a concern in terms of going into people's homes, particularly at the beginning of the first lockdown, where the crews were unsure of the COVID status of patients, to be fair, as were the patients. So that was very tricky. Also, the environment that paramedics in the ambulance sector work in, which is ostensibly a metal box on wheels, and with certainly social distancing guidelines that were being advocated, that was impossible in an ambulance. Certainly, two crew members driving to a call cannot be 2 meters apart. The cab doesn't allow that. And in the saloon in the back, where you're treating patients, both patients and crew are very, very close to one another. And there was a real concern from our members that they were either passing COVID on to patients who were already extremely unwell, or indeed, receiving transmission of COVID from patients who were unwell. So there was the autonomous nature and remote nature of ambulance work is such that you come on shift at the beginning and you're out for 8, 10, 12 hours depending on your shift, and you may never see any of your colleagues or managers, for example, in that time. So it's quite a unique environment, and I think the college really felt that that consideration wasn't really given. It's not just community work, it's more than community work, it's an emergency service piece where you're dealing with the health of the Scottish public. So we didn't feel that was really closely recognised.
In paragraph 32 of your statement, you talk about IPC cell guidance, and again, you didn't consider that that was appropriate for the ambulance environment. Could you firstly tell us what is IPC cell guidance?
So the IPC cell, from our understanding, was set up in England to take the evidence that was available from a number of various sources to try and determine what levels of guidance should be issued across certainly England, and that was fed into by the Scottish Rapid Literature Review, the RHI review, and that was a weekly short snappy literature review which fed into the IPC cell. And the cell would then distill the evidence it had and then update guidance around infection prevention and control in most areas of health and care. So it was under NHS England as far as we were aware. We never knew who were in the IPC cell or who was making those decisions, but I think they worked closely with NERV-TAG and a number of other bodies that were trying to decipher the evidence to provide the guidance at that time.
Was their guidance used by your members in Scotland as well, to your knowledge?
My honest answer is I think it was inconsistent.
Okay.
So it seemed like there was slightly different guidance in Scotland than there was in England, and that was where our members reported that was a problem. Was sometimes you do cross-border work where people who live right on the borders of England and Scotland, there would be inconsistencies in how crews, depending on which country they came from, would understand what the guidance should be for them. But predominantly, the IPC cell's guidance for ambulance staff was the fluid-resistant surgical masks, apron and gloves.
Yeah. Were there, you mentioned the masks, were there other shortcomings in IPC cell guidance in the opinion of the college, and what would the college have liked to have seen in the guidance, the IPC cell guidance?
So it became quickly apparent to us because of the nature of spread of COVID amongst our members and what they were reporting to us, that whilst, of course, good infection prevention and control through the hierarchy of controls is gold standard, that actually this wasn't stopping the transmission of COVID to our members and to the patients. So the evidence that we were all looking at, and I appreciate the IPC cell may have had sight of a much larger volume of evidence, but the evidence we were looking at was showing that actually there wasn't enough evidence to say that it necessarily was transmitted via an airborne route, but there wasn't enough evidence to say it wasn't. This was right at the beginning of COVID. So we felt that actually that was too risky to take a chance on an entire workforce, to say that actually we don't think there's enough evidence. However, what sickness rates, etc., are telling us is that this may be more than droplet spread. And we very much asked for that consideration to be given to those working in the ambulance environment, and that probably, stretched to anyone who was working in a community setting at that time, but particularly for us at the college, our members were incredibly anxious, particularly as the fluid-resistant surgical masks did not feel like PPE at all, and the aprons that they were wearing were not conducive to the environment. So you might come out of the patient's home or care setting, and the apron would blow up into the paramedics' faces. So anything that was on the surface of the apron was then blowing up into clinicians' faces, which seemed wholly inappropriate. However the virus was spreading. So it didn't, we felt the guidance didn't really account for that, and no one had really seem to think about that environment that people were working in, where they're in a patient's home. You know, they could be collapsed in a toilet, for example, or a really small space in their home. And there's no way that you could ventilate the areas that paramedics were seeing patients in.
Yeah, thank you. We heard evidence last week from another organisation which was of the opinion that in the absence of evidence, guidance should have required the highest levels of protection in accordance with the cautionary principle. This is a view that's shared by the college, is that correct?
Absolutely, and what we weren't saying is that everybody should always wear FFP3 and Tyvek suits. That was not what we were saying. What we were asking for is to say that the fluid-resistant surgical masks are sometimes not enough, and where our crews, who are autonomous registered professionals, are able to make a risk assessment, then they should, without question, be able to upgrade their PPE to a higher level in some of those circumstances I described. Yes. And there are plenty of other examples where a paramedic may want to wear greater protection because of, for example, a patient with asthma who's being nebulized, for example. There's a lot of exchange of air. It makes patients cough. It's very dry on the throat. It makes patients cough, and particularly around things like cardiopulmonary resuscitation. So there were many occasions where we wanted the precautionary principle to be considered until there was more evidence available. And as that evidence became available, we were very willing to then look at that evidence and say, does that mean that we can reduce the level of respiratory protective equipment in those cases? Or actually, is it best to keep the protection high? Because if you don't keep the protection high, not only do you risk infecting the staff and the patients, if the staff become infected to a greater degree, the workforce dwindles to a point where you run a very lean service and possibly not be able to cope with the amount of calls that are coming in. So it was very much thought about a broad range of reasons about why precautionary principles should be considered.
Thank you. And you touched on cardiopulmonary resuscitation, and I want to ask you about that because that's something that presumably paramedics might deal with more than other clinicians. I understand from paragraph 35 of your statement that prior to April 2020, CPR and intubation were both regarded as aerosol generating procedures, or AGP, but after that point, they were removed from the UK-wide AGP list. What are the views of the college regarding this reclassification?
Bemused, I think probably would be my best description, because we couldn't see how the evidence correlated with the removal from the AGP list. We saw there was one paper that was continually put out by Tran et al. In 2012, which was based on a hospital patients, a set of hospital patients who were paralysed and anaesthetised, and the aerosol generating procedures were measured there. They're not the patients that paramedics are dealing with. They're very often sudden cardiac arrests, and you know, I have to say, paramedics saw many more cardiac arrests during COVID than they have probably seen in their careers up to date, because people were so unwell and collapses were so sudden and swift that people weren't anaesthetised and paralysed in a way you might find in a hospital. Therefore, you couldn't control where the patient had collapsed, and that might be in a really poorly ventilated space. And it just felt, you know, when you are dealing with advanced airway management, chest compressions, and defibrillation, it just didn't feel like that had really been considered in the environment. We didn't find any evidence, weren't aware of any evidence that we could draw upon to say definitively that the AGPs should have been removed from the list. So we were asking for them to remain until such time as more robust evidence was provided.
Yes, thank you. What were the unique issues faced by your members in relation to administering CPR? And, you know, in part in relation to PPE, when to wear PPE, what type of PPE, but also separate to the issue of PPE, what issues arose for paramedics specifically?
So it's multifactorial and very difficult, both sort of morally, ethically, and you know, to be able to provide treatment. So as I said earlier, the undifferentiated nature of 999 calls means you could think you're going to a fall, for example, and find out that actually that fall is someone who has collapsed, but they're in cardiac arrest. So the crew then have to make a very quick decision, and the guidance that was offered at the time was that if you find yourself turning up to a patient who is unfortunately in cardiac arrest, then the first crew member should go out in type 2 PPE, which is the fluid resistant mask and the gown, start CPR procedures while the other crew member dons level 3 PPE, so FFP3 and a suit, and then comes over and takes over, allowing the first crew member to go back and upgrade their PPE. So morally, that's really difficult, because many of our members said it doesn't feel right to delay time to the side of the patient by putting the PPE on to determine whether they are in cardiac arrest, etc. And I am very confident in saying to you in this inquiry that many of our members went to people's sides without any PPE at all, with no protection, because the drive to support and resuscitate a patient is overwhelming. What that does, though, is it creates a sort of moral injury for paramedics, who then recognise that they may be dealing with a patient who is COVID positive. They've then exposed themselves to the virus, and they may then have to go home, and you know, they risk passing that on to their families. So I think that the lack of understanding about what was best to do made our members, and I think probably all paramedics and ambulance clinicians, very, very anxious that they weren't letting the patient down, that they were doing the absolute optimal best for their patients in every situation, but also that recognition that they had to protect themselves, particularly if it was in a poorly ventilated state. And I think I wouldn't underestimate the impact of that sort of situation on the mental health and well-being of our patients, of our staff and our patients. But also, if a patient had collapsed at home, the crew may well have needed to take that patient in, and normally you would extend the family coming with you, so that there is closure for that family, or there is the opportunity to see the work that's ongoing on the patient, that you're trying your absolute best. And because of lockdown regulations, the family members could not travel with the patient whilst CPR was ongoing. So it is multifactorial.
Thank you. I want to ask you about do not attempt CPR decisions. Do you know whether your members noticed a rise in the number of people in respect of whom DNA CPR decisions had been made?
I couldn't say definitively for that. What we did know is that we're very used to seeing do not attempt CPR forms and legislation around that with patients. What our members were finding during COVID is sometimes people had deteriorated so rapidly that none of those conversations had happened. So there was no documentation or paperwork in place, but I couldn't say definitively whether we saw more of those than not. I can find out for the inquiry after this session.
Thank you. Where they discovered that such paperwork or decisions weren't in place, but to them it seemed that it might be appropriate, were they left to have that conversation with the family, or would they just attempt CPR?
The crews will always start CPR. There is always, the time onto the chest is so important. So the conversations may well have started to happen once the history of the patient's collapse then came to fruition. So if there had been a patient who had been extremely unwell, who had multiple issues with their health, who had shown deterioration over many days or weeks, the family may then at that stage bring up the case of actually they don't want their loved ones resuscitated, and then the paramedics and the clinicians have to make a really difficult decision about taking people into hospital, given the fact that there is this virus that is creating a huge issue. So very difficult decisions to be had at the scene of a cardiac arrest. That happened much more frequently than I think any of our members had ever seen before. But if there was ever any doubt about resuscitation, paramedics would absolutely resuscitate and take to hospital.
Thank you. I wonder, can you tell us, can paramedics access a system that has a record of DNA CPR decisions, or are they reliant on a note being visible within someone's home or a family member telling them about it?
It can be inconsistent. Sometimes the access of information, certainly in remote or rural areas, is tricky, and it's not consistent. So the proof normally is to see something that's normally left with the patient through a number of healthcare professionals. It could be the GP or the community nursing team, and there would be evidence there that the crew could find easily. Some electronic access to information isn't always consistent.
Okay, thank you. You state in the last sentence of paragraph 40, we understood from our members that they felt very strongly that they should be trusted to make their own decision about appropriate PPE. What happened if a paramedic wanted to use more PPE or PPE that offered a higher level of protection?
We found that there was a minority of our members who gave some quite harrowing accounts that if they had made a judgment on scene to use higher levels of respiratory protective equipment, that when they returned to a station, it may not be their own, but to a place where they could restock, they were often challenged around why they had, what was the job that they'd been on that required them to use the higher level of respiratory protective equipment. And sometimes the members told us that the equipment was actually locked away. So they couldn't access it unless they had given a rationale as to why they'd used higher RPE, when the guidance said that you should be okay using fluid-resistant surgical masks. So that was very incongruent to us in terms of, as I say, paramedics are registered autonomous pre-hospital clinicians, and if they make a dynamic risk assessment about a situation, then they should be trusted to do so rather than chastised for doing something that they feel is better placed for them in that particular situation.
Thank you. Now, we've heard from other organisations that the burden created by the pandemic led to burnout and a reduction in their memberships as people left their professions. And I understand from paragraph 46 of your statement that this is also the case in respect of paramedics. Is that correct?
Yes.
Did your members feel underappreciated?
Certainly in the we did 2 surveys with our Scottish members, and that came out as a common theme in both. We did one survey very soon after the pandemic, the lockdowns finished, and one relatively recently, and they did feel that they were undervalued, and that certainly left many people. The members who we have lost certainly seem to be they're not even at retirement age. These are people who may have been in for 10 or 20 years within paramedicine, and who through COVID have just decided that this is no longer for them. And there may be a number of factors that add to that, but certainly just that feeling of being underappreciated and not well cared for, and having managers that showed that compassion in areas did affect our members. They told us that very clearly.
Mm-hmm. Can you tell us about the wider impacts of low morale and the decline in paramedic numbers?
So the low morale manifests itself in a number of ways. So that sort of value of coming to work and being able to do a good job lessens, and what we see is the absence for anxiety, sickness and depression has increased exponentially compared to pre-COVID levels. We also have seen a number of paramedics who are accessing specialist services for their health and for their mental health and well-being, and really not wanting to continue in this career. What's changed, I think, through COVID is people were leaving beforehand, not in the same number, but they were going into other areas of health or care. And now our members are just leaving health altogether and sometimes taking either early retirement or doing very, very different roles outside of health or care, which is not something we'd seen before. Likewise, you know, we need a pipeline of paramedics. It's a 3-year degree program, and we need the wisdom and experience that our paramedic workforce has to stay in the ambulance sector, to be able to nurture the newly qualified paramedics coming through the system, to be able to pass on that wisdom and experience so that patients get the best care possible.
Thank you. In paragraph 51, you state the ambulance service had a target 15 minutes to hand over a patient to the emergency department, with a delay of 30 minutes being considered indicative of a problem with the system. And in paragraph 52, you state an average handover during the pandemic would perhaps be between 4 and 6 hours. And in a subsequent paragraph, you state that in January 2020, delays reached between 10 and 12 hours in freezing conditions. Are these Scottish numbers, or are these UK-wide averages?
Some of them are Scottish numbers. It's really difficult to extrapolate one, you know, the UK-wide and the Scottish numbers. But we know from our members, as members in Scotland, that some of the hospital handover delays still remain. They were prevalent during that period of COVID, and that where paramedics found themselves, as I said, there was, you know, paramedics working in a box on wheels, and they found themselves sitting with those patients waiting for much more time than they had ever experienced before. So you tend to find that some hospitals have incur more delays because of either the way the estate is laid out, or the staffing numbers at the receiving hospital, or that ability for hospitals to create flow through the system, and also the discharge of patients into community care afterwards can back up the delays at hospital. But we know even today in Scotland there are ambulance handover delays, and that's no different to during COVID, and it is something that has become normalised in our view that shouldn't be.
Thank you. And do you know whether the numbers reflect both adult and paediatric handover times?
Yes, to the main extent, yes. The ratios haven't changed at all. What our members were reporting to us, and some of our Scottish members would, I remember a couple of anecdotes where they had pre-alerted patients into hospital. One was a child and one was an adult. And a pre-alert means that you advise the hospital in advance that you're coming in with someone who is quite poorly. And you use blue lights and sirens to make your way to the hospital in a much more expedient way. And normally when you get to the hospital, they're waiting for you and ready and have a space, etc. And both of these members from very different areas of Scotland said there was no space. And we had to, despite blue lighting in, we had to wait outside until space did become available. And that's just not normal at all. You know, the crew have made a decision that someone is so very poorly that they need to get to definitive care urgently, and that lack of ability to then take that patient in when clearly they're still suffering from a medical emergency is unprecedented.
In your opinion, why did this become the case? Why did waiting times increase so much? Or handover times, sorry.
I think that, again, it's a multifactorial issue. I think initially during COVID, the demand for ambulance services dropped, and Scotland as well, that showed no difference from the rest of the UK at that time. And then gradually the demand has built and built to the levels we're probably seeing today. And sometimes the demand, if you look back 3, 4, 5 years, you could say the demand has almost reach those normative levels, but what's changed is everything else around it. So you may find that there's less workforce both in the ambulance sector and the ED and the rest of the hospital. There may not be the money that's required to put the community packages in place for people to be discharged appropriately, and when people are discharged, sometimes our members have reported that they're going back to conditions that are less than optimal, and people are, I think it's common knowledge that people are in hospitals for far too long, far longer than they should be. So it's multifactorial, but what ends up is a bottleneck at the emergency department, and therefore the ambulances queuing outside, which then means the ambulances aren't available for the 999 calls in the community.
Does the college have any views on what might have helped with keeping handover times shorter?
I think what I would say worked really well for our members in Scotland during COVID was the ability to access senior support. So the sort of normal barriers that might have prevented that all seemed to sort of melt away during COVID, thankfully, and crews were able to access maybe consultants in a specific area who they could have a chat with whilst on scene with a patient to say, does this patient really need to come in? And they may have a plan put in place that meant the patient could stay at home, didn't need to come into hospital, or speak to senior decision makers within the ambulance service themselves to make some of those decisions, or indeed use sort of technology to view the patient before a crew had even got there. So some of that system seems to have gone. I think Scotland are definitely keeping some of the technological aspects in place, which I think is an exemplar for the rest of the UK. But it is that I think there's probably about a 47 to 49% transportation rate for ambulance services right across the UK, where not everybody comes into hospital anyway. So it's not that every patient is going in, but those patients that do need to go in probably need risk stratifying with all involved in their care to say, is hospital the right place? And if it is, then obviously they need to go. If they can be helped and held in the community, then that's probably much better for the patient and for the ambulance service and the ED.
Thank you. What were the consequences for paramedics of such prolonged handovers?
So initially, there was obviously the fear of the virus itself. So paramedics would be sitting with a patient for hours on end, and what their concern would be is of course the virus had its own anxiety, but the ambulances are not built for a comfortable, prolonged time in them, and patients do not anticipate sitting in the back of an ambulance for hours on end. So there is a sort of health and well-being aspect for both parties in that sense, and certainly for newly qualified paramedics, you would anticipate seeing a number of patients per shift. And sometimes crews were seeing one patient and sitting with that one patient from the start of their shift to the end of their shift. And in really extreme cases, crews were being sent to relieve the first crew at the end of their shift, and another crew would take over so that crew could go home. So, we were dealing with situations we had never encountered before, certainly from a member perspective.
And do you think that issue impacted the time that people had to wait for ambulances to arrive with them?
Undoubtedly, because if the mode of transportation is tied up, then you're very much reliant on speaking to someone on the phone or trying to use technology to access that patient if they have the option to do so. And I absolutely understand patients were frustrated, anxious, frightened, and sometimes downright furious that they had expected an ambulance to come quickly, and sometimes patients were waiting for hours for ambulances, and the next crew that were available to go to that patient may well have faced sort of verbal and sometimes, unfortunately, physical abuse as a consequence. But it's understandable that patients are calling for an ambulance with absolute expectation that one will arrive in a timely way, and that couldn't happen.
Yeah. In paragraph 54, you state that during the pandemic, it became common practice for hospital staff to check on patients in the back of an ambulance to see if there was any deterioration. You state that at times they would even have diagnostic tests done, then be returned to the ambulance to wait for results. Again, did this apply both in adult and paediatric cases?
Less so in paediatric cases from our members' statements and surveys, but certainly for adults. If children and young people were a low priority medically, then it could happen and did happen on very rare occasions. But most of the time, this was for adult patients.
Was this down to a shortage of beds within a particular hospital when they were then being taken back out, or lack of waiting areas even? And yes. Were paediatric hospitals better resourced in terms of those areas?
I think sometimes it was both. Again, the normalisation of ambulance handover delays are the corridors, and the corridor care is really not popular. It's not optimally sufficient for patients. You can't monitor them as easily, and they're not in the sight of the emergency department staff. So I guess if you're in the ED and you know that at least the ambulance crew are with the patient and monitoring them for any deterioration, that's the least worst scenario. But the children certainly seem to have a quicker ability to be able to be placed somewhere in the hospital. I think it's whether it's right or not, I think children and young people certainly sort of stick in people's mind very much that they don't want them waiting outside unless there's something like they consider a sprain or a strain where actually it's not a medical emergency, but they do need to rule out a fracture, for example, and then they might just need to wait a short time until they can get X-ray available and some space. So it was a complex situation.
Thank you. You mentioned that in your statement there that leaving someone with a fractured neck of femur in the back of an ambulance for hours doesn't improve their outcome, and that's one example. Does the college consider that patient welfare and care standards were compromised as a result of these delays?
I couldn't say anything different. I think they absolutely were compromised despite everybody's best intentions. I think patients' perception was that they would be taken to hospital and moved into the hospital and find a space there where they would be cared for. I don't think in terms of the compassion of the care that was given, I don't think the standard of that was dropped anywhere, either in the back of the ambulance or in the ED. But I think physically, and in terms of patient outcomes, it will undoubtedly have had an impact on patient care.
Thank you. We've heard from some that they were told or had an impression that ambulances were told not to take care home residents or people who had COVID to hospital or to take them in their ambulance. Is this something that your members reported to you, being told not to take people in either of those categories in their ambulances?
No, not that. From my recollection, there was one or two members who had difficulty around care homes, but it certainly wasn't. Normally, from the college perspective, when you hear things multiple times across multiple areas, you can tell that that's a theme or a trend building. There was certainly concern about the care homes, particularly if people were going back from hospital and discharged back into the care homes, but coming in, what our members told us was that they invariably had time to put on their PPE, and unless it was a medical emergency, they were able to take their time and go specifically to that patient. But certainly from a college perspective, we didn't hear anything other than that.
Thank you. In paragraphs 58 to 78, you talk about communication and guidance. How much of a role did the college play in interpreting and adapting guidance? Scottish Government guidance for paramedics?
So I think the college recognised that we were a smaller voice in during COVID, and it's understandable. I'm sure from a government or an arm's length body perspective, during this time there was a lot of noise coming at them from a number of organisations. So the college joined with an alliance of members, including the British Medical Association, Royal College of Nursing, etc. And we were just trying to get the same message across to everybody that had the ability to influence policy and decisions, to say that there are key things that we really feel need to happen. One is this precautionary principle for protecting our workforce, and the other is to consider the procedures and environments that many of us are undertaking. So, for example, our cardiopulmonary resuscitation and the fact that as new variants came through COVID, we were seeing sickness rates ebb and flow with the new variants, and we were keen that as part of that alliance that we had some very paramedic or ambulance sector specific messages in there that could be landed with Scottish Government, and I think you'll probably see from my evidence that we've engaged in a number of conversations through letters with this alliance to try and get our message across.
Mm-hmm. Yes, when you contacted individuals in the Scottish Government to raise issues specific to paramedics, what sort of responses did you receive?
I think there were only two responses that the alliance received. That was it, as far as I was aware. I think everything's been shared with the college that was received back. There was nothing we received.
How well do you think the college was listened to by the Scottish Government and government organisations?
I think on our own, I would dare to say we weren't listened to at all. As part of the alliance, I think there was a consideration that there were professions out there that perhaps needed some closer scrutiny. But when you're dealing with a pandemic, I have no doubt that it's incredibly difficult to try and juggle everything at the same time. But we felt unheard, and our profession felt unheard, and what we could see was our members living through this every single day, worried about their families, losing family members, losing colleagues, and it just felt the imperative was so great, but we clearly didn't land our message in the way we needed to.
Where members in the college considered that their interest in welfare wasn't being adequately considered, did the college issue its own guidance to members, for example, in relation to appropriate PPE during aerosol generating procedures?
We certainly did. We felt that having, you know, we've got a research advisory council, and certainly through integrating with them and with other stakeholders, we felt very strongly that members should have the choice to upgrade their RPE if they felt that was necessary through their risk assessment. And as I've said in my statement, the Royal College of Nursing provided a really helpful risk assessment process that we asked the Association of Ambulance Chief Execs to review and pass on and consider. But it was very much, I think there was just, we recognised we caused anxiety for our members. We knew that because we were saying something that countered what the national IPC guidance said, but we didn't believe that the national IPC guidance had considered A, the environment that paramedics were working in, and B, the growing evidence that was saying that there is an airborne element, a very large airborne element to COVID, that it just felt people weren't recognising and considering.
How did your members deal with the times where guidance from the college was different to guidance from other organisations? And was the college able to step in and support them in potentially, conversations with their employers?
I think it made people anxious, and we certainly did a study, the CARA study, which looked at 3 phases during the pandemic, both pre-peak of the pandemic, the peak of the pandemic, and just post the peak, where that was one of the questions we asked, because it is fair to say that we recognised that we were saying something that was counter to national guidance. What we did was we said, here are ways that you can tackle this with your employer. Here is the evidence that we're looking at, and you're very welcome to use that. And this is where we relied on some of our stakeholders, like the Resuscitation Council UK, who had evidence around that as well. And what I was doing was meeting with the Association of Ambulance Chief Executives on a regular basis to say, this is what we're saying, this is why we're saying it, and I need you to hear that. That obviously makes your employees nervous, but surely there's a compromise, and surely you can see why we're saying what we're saying, and here's the evidence for it. What I couldn't see, if I'm honest, was the evidence coming back the other way to say why they weren't moving their position on that. So we just felt it was right as a professional body to give our best opinion based on the research and evidence, and we felt we couldn't do anything but that, recognising it would make people anxious.
Thank you. In paragraphs 88 to 92, you talk about the impact on patients and paramedics. Can you tell us, did the suspension, or in your view, did the suspension or reduction in primary care and screenings affect the type of cases paramedics encountered?
Yes, I think that the case mix of what paramedics were seeing certainly changed, and some of what would be traditionally primary care work, including things like repeat prescriptions, for example, or trying to access a particular service, by default became something for the ambulance sector. And I think Scottish Ambulance Service, I know, tried really hard to triage those calls out to try and didn't want to send an ambulance to those calls necessarily because it wasn't ambulance related and didn't require an ambulance. However, sometimes people get very confused and will call because they're not really sure what else to do, and it's very difficult to unpick that sometimes in a call. So some of our members did end up going to calls that were really not for ambulance transportation to hospital or indeed ambulance related, but ended up trying to be conduits to services, and sometimes spent a long time on scene trying to access services that were very difficult.
Thank you. And what impact has all of that, encountering these cases and working in these situations, what impact has that had on the mental and physical health of the profession?
Again, I think it's multifactorial. So there is. I think sometimes some of our members felt that this was not within their skill set, not within their gift to be able to help a patient with some of these queries. There's frustration that the system seemed to be putting everything onto the ambulance sector and them particularly. And sometimes people were very anxious. We saw right across the UK that some patients left it much longer than they would have done before they sought help for specific conditions, which often made them much sicker by the time that the crew had got to them. But it's that frustration of not, if the patient doesn't know where to go, the ambulance crew aren't necessarily going to know how to access some of those services or get a repeat prescription, for example. And despite the best signposting you can give, if the services are running, really thinly because of their own workforce absences, for example, then it makes it very, very difficult. So there is a sort of psychosocial element to this, in that paramedics want to go out and do ambulance work. They want to do the very best they can for patients who are, have limb or life-threatening conditions, who are requiring of their skills. And quite often now we see it's more around sort of primary or urgent care conditions, because I think the patient population has changed in the way it wants to access its health and care.
Thank you. Now, I'm aware from your statement, and you've mentioned that the college carried out 2 surveys of Scottish members to gather their thoughts on issues such as mental well-being, PPE and guidance, and we'll consider the results of those surveys alongside the entirety of your written statement and your oral evidence today. Is there anything we haven't covered today that you would like to highlight?
I think I would just like this opportunity to pay tribute. We lost paramedics. They lost their lives through COVID, doing a job they love. And I think this seems an opportune moment to just pay tribute to those, some of whom came out of retirement to support the work that was required. And paramedics feel very strongly that they're in patients' times of need. When during lockdown, patients were anxious and frightened and lonely in some cases, and concerned, and paramedics didn't stop providing that care. And I would really want the Scottish public to know that paramedics will remain with them now and in the future, despite whatever happens. But I guess for me, I would really strongly recommend that the inquiry considers the mental health and wellbeing impact on our profession. We're starting to see a reduction in those coming through the pipeline for paramedicine, and as I say, people leaving, and the retention of paramedics is going to become more challenging. So just to address that mental health and wellbeing of our members would be really important to me. But other than that, no, and thank you for the opportunity to come and talk to you today.
Thank you very much for your time. And
yes, thank you, Mrs. Hope. Miss Hope, I beg your pardon. Thank you very much indeed. Good. Now, again, we're a bit early. I don't know if the next witness is here. Do you by any chance know? Sorry to put you under that. Oh, you can't be blamed for that. Right, it may be possible to start, say, at 1:45, but I can't promise, I'm sorry. It would be good if we could, but it depends on the witness being here. In the meantime, thank you very much. 1:45, but if not, 3 o'clock. Now, good afternoon, Mr. Edwards. Good afternoon, Mr. Hope.
Afternoon.
Right, when you're ready, Mr.
I am.
Edwards.
Thank you, my lord. The inquiry will now hear the evidence of Mr. Ewing Hope, who is currently the chair of the Scottish Unite Health Committee. Good afternoon, Mr. Hope. Can you give the inquiry your full name?
Ewing Hope.
Ewing Hope. And you have before you a witness statement, I hope?
Yes.
Yes, that's right. And you confirm that that is your witness statement?
Yes.
And you've had an opportunity to read through it?
Yep.
Yes. Thank you. And you agree to your witness statement being published?
Yes, I
Yes.
do.
And also to your evidence today being recorded?
Yes.
Yes, thank you very much. Lord, the witness statement of Mr. Hope has the reference SCI WTO 443, 5 zeros and a 1.
Thank you.
Now, Mr. Hope, you have provided quite a substantial statement for the inquiry, and I thank you for that. And there are a number of matters which have headings, the first of which is in relation to PPE, and the second of which is in relation to infection and control. The inquiry has heard quite a lot of evidence already about various difficulties with PPE around matters such as the availability or lack of PPE, what you describe as the sporadic allocation of it once it was available, and then issues associated with the effectiveness of PPE. Now, although I understand that this is very important, because the inquiry has heard quite a lot about PPE problems, I'm going to take that part of your statement quite quickly. So, in relation to the lack of PPE, what you say in, I think, paragraph 9 of your statement is that things changed from the start of the pandemic as the pandemic progressed. Yeah. And what you identify in paragraph 9 is a lack of PPE, and then as it started to become available, what you say in paragraph 10 is confusion over PPE. So do you want to say a little bit more about that? What do you mean by the confusion around PPE?
So in the early days of the pandemic, the use and need for PPE was not very well known, not very well acknowledged within the organisations. And therefore you had particularly community staff who were going into patients' homes on a regular basis, and they didn't have the same access to PPE as those in an acute setting, and therefore that became problematic. Again, government guidance was coming out to focus primarily on particularly patient closeness for the use of PPE, and then we spoke about sessional use and about recycling PPE in the early days, which just didn't sit very well. So that distribution and availability was very, very low. The employers, or NHS in general, wasn't really cited on the need for PPE at that particular time as being a priority, although from a staff side perspective, staff safety was always our number one priority, because unless you can ensure staff safety, then you're going to have difficulty ensuring patient safety. So we were arguing it purely from a safety perspective, and it was falling in dead ears initially, but it got to the stage, and I make the point in the statement, that the staff side, both nationally and locally, made the decision that unless we could provide PPE and safety to our members, we'd advise them to do that risk assessment, and if they felt endangered, not to be providing services until they were in a safe position. And that's when that change in relation to the organisation's priorities becoming the need to get PPE, because without that you weren't going to have services.
Now, you were in a position to know about this because you are the chair of the Scottish Unite Health Committee. Yeah. So can you say something about the Health Committee and your responsibilities with it?
So the Health Committee meets in a normal process about 4 times a year every quarter, and it's always in person. When the pandemic hit, I was the vice chair at that particular time, but the chair wasn't very well, so I chaired most of the pandemic meetings. But because we're using Zoom and media platforms, it's far easier to get meetings. So during the pandemic, we were meeting on a regular basis. our health committee is made up of representatives for every health board and every special health board. So you've got that, and because of the nature of Unite, the diversity amongst the committee is we can go from, our membership rather, you can go from a domestic to a director, or from a cleaner to a consultant, because we've got such a wide. So we've got that breadth of knowledge within the health committee, so that we've got rich dialogue about what was taking place and what we were missing.
Yes. Now, the Health Committee is a national body.
It's a Scottish body.
A Scottish body, yes, yes. But you have particular responsibility and specific knowledge in relation to the Ayrshire and Arran Health Board.
Yes, so within NHS structures, Ayrshire and Arran, we've got 15 different trade unions. For every 4 years, elect a staff side chair, who then gets appointed to the board through Cabinet Secretary. And you assume the mantle of employee director, which gives that individual more access to more senior management team meetings and dialogues. So the range from a normal rep to where I was sitting at was far, far different. But the other part of my role during the pandemic was to make sure that I had regular meetings with the collective staff side within Ayrshire to provide guidance, instruction, but also to hear their concerns so as I could feed it back through that management structure and then back up into the board.
Now, in paragraphs 12 and 13 of your statement, I mean, I make that link between your role in the Scottish Committee and your work with Ayrshire and Arran, because in paragraphs 12 and 13, you describe what you call bronze groups, which were set up within Ayrshire and Arran, whose role it was to make sure that there were regular supplies of PPE coming in. Now, the bronze group, is that something particular to the Ayrshire and Arran Health Board?
No, that was the command and control structure. So you had Gold Command, which was your emergency management team, and then you had your Silver Command, who was at an operational level within senior management. And the bronze groups were more working groups, if that in fact clarifies it. So they had that responsibility to do the work that was required to access PPE.
But this structure was not just particular to Ayrshire.
No, that was a Scottish-wide structure.
But in paragraph 13, you say that Ayrshire and Arran set up PPE champions.
Yeah.
Yeah. Now, was that something that was particular to Ayrshire and Arran?
I think initially it was, but that was rolled out to the rest of the country.
Right. And what was the main purpose of the PPE champion?
Certain groups of staff within a health setting will use PPE on a regular basis. The majority of staff will use certain parts of the PPE, whether that be gloves or aprons, but the mask, gloves and aprons has to be donned and doffed in a particular way to prevent infections for the individuals. So that training of staff in how to don and doff PPE was really, really important, because that again reduced the risk of transmission of COVID.
In paragraph 15 of your statement, you use an interesting expression, which is that staff became PPE exhausted.
So,
do you want to say more about that?
If you go back to the original statement I just made, majority of staff will use certain parts of PPE, but not on a regular basis. So staff were getting, when I say they became PPE exhausted, what I mean is that the donning and doffing would probably slip, or the inappropriate use of PPE, doubling up of gloves, etc. So staff were, the guidance was changing so often that it made it difficult for staff to follow the guidance every time. But the longer the pandemic went on, staff became more and more, and I will use the word exhausted by the use of PPE, because it was a strain on them.
Mm-hmm. Later in your statement, you talk about problems with training during the pandemic. Yes. Were these problems also, did they also exist in relation to the use of PPE? Initially
they did, but then and I go back to that statement about the infection protection control teams. Mm-hmm. So they were primarily our PPE champions, so we were taking them away from one part of the organisation where they were needed to undertake training for staff in the wards and in clinics.
Yes. And then in relation to masks, like many other witnesses, you identify various problems with the availability of masks and then the effectiveness of masks and expiry dates. Yeah. Anything more that you want to add about that, in relation to masks in particular?
The mask thing, and again, if you take the FFP3 masks, which are face-fitted, and you have to go through a certain process, and it's timely, but to make sure that that mask has got a real close seal, and you're not going to be breathing in anything from the sides of it. But the problem with them is that they were based on male faces, so the majority of our workforce are female, and therefore getting face-fit masks for smaller faced females was really problematic. And if you couldn't get that face-fit, then you had to move your role to where you could use an FFP2 mask. What that meant is you're taking really experienced staff from one part of the organisation, which they're highly trained in, particularly about ICU and HDU, and moving them into other parts of the organisation. So that skill mix get impacted upon by our ability to ensure patient safety, or staff safety, through the correct FFP3. So that became problematic. The fact that initially everybody in the country was looking for the same suppliers of face masks, particularly FFP2, and that became problematic because, again, everybody's fishing in the same pond for the same commodity. So we started importing it, and one of the masks that came in, it was called a tiger mask. I believe it came from China. So rather than having the elasticated loops for the ears, it had the ties, which was stuff to use years and years ago, and what that meant is there were huge gaps at the sides of the mask, and they just weren't fit for purpose and provided no protection. Staff were told unceremoniously that that's what they had and they had to use it. And it wasn't until the trade union stepped in to say these are unacceptable, these have got no impact on the staff safety, and therefore if that's what we're going to be using, we go back to that risk assessment and whether staff are going to be able to provide the services that you require us to provide. And that's when we get rid of the tiger mask and go back into the supply of elasticated loops.
Yes. And then in paragraph 20, you make a, well, you've just made it, but just to be clear that I've understood correctly, you make a point about not so much the availability or lack of PPE being a problem here, but the effectiveness and the ability to wear it effectively led to deployment issues.
Yes.
And so you could get ICU, that's intensive care unit nurses, because they can't use the PPE properly or the face mask because of their physical build being allocated to other areas.
Yeah, but so you take them from that area where that is a requirement because they're doing aerosol generating procedures and put them up into a ward where they're still very ill patients, but again, it's the skills they have for the ICUs, which is slightly different or considerably different from the skills in the ward-based unit.
So is it fair to say then that some of these PPE problems led to staff being deployed not necessarily according to their skills?
Yes.
Is that right?
Yeah, absolutely. And that's the point I'm making, because again, it's about providing the staff with a safe environment in which to deliver their services.
Mr. Hope, as I'll say at the end, of course, the inquiry will have the benefit of your whole statement, but before we leave PPE, is there anything else you would want to say about PPE and the issues that arose during the pandemic?
We weren't prepared as a country for COVID, and we certainly weren't prepared as a health service. So if you watched what happened in Wuhan, and we could see it on a daily basis in our TV sets, and what happened in North Italy, we knew that it was coming in our direction, but that preparation to ensure staff safety never crossed our leaders' minds effectively. And it wasn't until the staff side raised the issues about staff safety that they then became a priority, because the reality is we focused on emptying hospitals rather than providing safe environments for our staff and my members. So I think that, for me, that was one of the biggest downfalls. We knew it was coming, but we were not prepared.
Thank you. Now, the next two sections of your statement begin at paragraph 21, and the first one of them is about infection control, or infection prevention and control, I think you called it. And the second is about REDOR, and just to be clear, REDOR stands for the reporting of infectious diseases and dangerous occurrence regulations. Yep. So we will refer to that as REDOR. And if we begin with issues around infection prevention and control, in paragraph 21 of your statement, you focus in on what you refer to as the proper assessment group. Yep. Yes. Now, can you say something more about that?
So if you get, pardon me, if you get an outbreak within a hospital setting, then we set up a PAG, as the problem assessment group, or the other word terminology would be an incident management team, which brings together senior clinicians, staff side, nurses, doctors, infection control, labs, estates. So we look at the primary case first, and then we follow that individual through the hospital, and you can tell what room they've been in, who their nurses were, where they were at a particular time. So you can follow the patient's journey. And what that allows you to see is where the transmissions would take place, because then your second cases and third cases would come on respectively. Therefore you can see the spread. Because infection rates were so high and outbreaks were so high, we initially were running IMTs, but it became so busy that we were unable to, and therefore that learning of how the virus spread through a health setting, we lost that opportunity. So rather than investigating it, we were getting it reported twice a week through our COVID oversight group.
Yes. So the first distinguishing feature of a PAG, a proper assessment group, is that it focuses on when a patient comes into the hospital with an infectious disease. And the exercise allows the hospital to identify where they've been and who may have been contacted. So what you're saying in paragraph 22 of your statement is that in the early stages of the COVID pandemic, and in this regard you're only speaking about Ayrshire and Arran Health Board, they did carry out the PAG exercise? Yes. But that fell apart?
Fell apart because there were just so many. So outbreaks became normalised, and it was reporting of outbreaks rather than investigation of outbreaks.
Right, and then in paragraph 23 you refer to what substituted PAGs, yes?
And that was the oversight group, which was effectively our infection protection control teams, collated the numbers and the dates, etc., and brought them to the oversight group so as you could see where each outbreak was and which ward, which hospital, etc., and how many staff were infected and how many patients were affected. But that deep dive investigation into how it took place or how it was created, we lost that ability. But I think that weakened our fight back our responses to the COVID infections.
The weakening being that
we were firefighting rather than being preventative.
Well, you weren't able to identify where in the hospital it was located. Yes. I mean, what do you say should have been done then?
I think we should have had a dedicated team who looked purely at COVID outbreaks and did that deep dive and followed the patient's journey so as we got an understanding of where the transmissions took place within the hospital setting, not only for patients but also for staff, because again it's about that staff interaction with COVID positive patients, and you could follow the journey, but you could also break the spread if you knew where it was taking place.
Now, turning to REDOR then, which you begin talking about, I think, at paragraph 24 of your published statement, the contrast with a proper assessment group exercise and a REDOR exercise is what?
So the PAG would look at the infections within the department and the ward, and it's patient-based. REDOR is looking at the impacts on staff and where staff contracted or came into contact with COVID. Two completely, although they're joined for two separate investigation purposes.
Right, so the focus of the REDOR exercise is to identify staff who have been exposed. Yes. Yeah. And what happened to REDOR exercises during the pandemic? Beginning with the start of the pandemic.
My understanding is that the Health and Safety Executive made the decision that COVID-19 was a community-based transmission, and therefore they did not expect to see REDORs as a result of it being in the workplace, which made little sense considering as soon as you brought the community into the workplace in our setting, in a healthcare setting, then that became the transmission zone. But that was never rescinded.
So just so as to understand, what you're saying is a REDOR exercise was about identifying contamination, for want of a better word, in the workplace. Yeah. But as you recollect it, according to paragraph 25 of your statement, the Health and Safety Executive issued guidance that REDORs were not to take place in relation to workplace
They didn't expect it because it was a community-based transmission and not a workplace issue. I believe, and I can look back historically, that probably was based on the very first cases within the UK back in January 20, where Public Health England published that their findings was that this was very low risk to healthcare staff, and it was a community-based, and it was a moderate risk within the communities. So that early findings, I think, swayed one or two other outcomes as we move through it.
But to use a word you've used previously, I think it emerges from about the middle of paragraph 25 of your statement, it's quite a long paragraph, that some redoors were sporadically carried out.
Yeah, so if you have a staff death, then it's an automatic rid-on within the workplace. Right. When you had some more high-profile cases, and we had one or two of them within NHS or Sunan, then that drove the need for a further investigation, and therefore that then uncovered the need to make a rid-on report. So there are one or two. NHS or Sunan were probably the highest held board in the country to submit rid-ons during the COVID pandemic. And again, I think that was due to staff side who were constantly arguing about the need for rid-ons and the need for staff side to be involved in these investigations, which we weren't, but we continually made the argument about the need for rid-ons.
So although the Health and Safety Executive, as you recollect it, indicated that there were not to be redoors, still some took place, yes. And that would be when there was a death, is that right?
That's an automatic rid-on,
right.
Or
a death of a staff member.
Death of a staff member.
Yeah.
So the rid-ons is purely about staff. So, and again, it was about that forcing the issue by the staff side in general about the need for rid-ons that we did win some of the arguments, and some of them we didn't, unfortunately.
But it's also true in paragraph 26 of your statement, you say that, as you remember it, the first redoor that was submitted in Ayrshire and Arran was where there were multiple deaths in a coronary care ward in one hospital. Well, that was patient deaths, wasn't it?
That was patient deaths, yes. Because, and that was,
so what prompted the redoor?
That was one of the high-profile cases, plus
right.
All staff who care for patients are really protective and care deeply about their patients, and the staff in this instance who, unless we did that deep dive rid-or, that focus of the potential it was the staff who infected the patients, and therefore they caused the deaths, and therefore we needed to have a proper investigation, which then uncovered that the staff were contracting it in the ward, as opposed to bringing it into the ward. So it was high profile, there was a lot of discussion about it, and it needed a proper investigation, and that was the result.
Can you remember when that was, when that redoor was?
That would probably be April, May. It was quite early on.
Of 2020,
yeah.
Was it? Yes, yes.
I could be wrong with the dates, but it was fairly early on in that phase of the pandemic.
And a redoor results in a report, does it?
Yes.
And is that published, or?
No, it goes to the Health and Safety Executive, and then that's then recorded where it needs to be recorded, that is a workplace injury or infection.
Now, in paragraph 29, in paragraph, yes, in paragraph 29 and 30, you indicate your view, you state your view as to why redoors were not done.
Yep.
Which is what?
Purely because that, one, the Health and Safety Executive made the decision that was community-based, but I also think there's an element in relation to liability thereafter of workplace infections and personal claims. So I think that, I've got no doubt there was a financial part to that decision-making process.
Now, in paragraph 29 of your statement, you discuss some alternatives that were considered at the time to identifying the source of transmission in hospitals. So do you want to say? So
this was around about 2021, just after the Christmas period and the second lockdown.
Right.
And infection rates were getting higher and higher and higher, and government had, for some unknown reason, they decided that, in their opinion, it was because staff were infecting patients, and therefore they set up a compliance task force group. at the request, I'm led to believe, by the Cabinet Secretary, who was Hamza Yusuf at that particular time, to look at how we could identify either staff to staff or staff to patient transmissions. And there was a clear inference that there was staff who were transmitting the virus within a hospital setting. When they came and again, I was there representing National Staff Side, when we'd first met, I asked to show what evidence they had, what information they had to suggest this is how it was taking place. Because if there was a lack of investigations that we'd been calling for the best part of a year had never taken place, how did the government have that level of data? And we were asked to see the data, they clearly couldn't provide it, so it was purely on a hunch.
This is data about
staff,
the level of staff infection, yes.
So they didn't have that data, so their response, or one of the responses were, apart from communications, etc., was that staff would be more compliant if they knew they were being watched. And there was a suggestion that we put body cams onto nurses to make sure they're compliant with regulations or with guidance, which I found, I was astonished initially, but then I was deeply offended by the suggestion that that's where government went. So in their eyes, our staff went from being superheroes to supervillains overnight, without any evidence.
What happened to that proposal?
It came to that group, it came to myself, and I made it perfectly clear that staff side would never accept that as being an appropriate use of an invasion of staff's privacy. And if they wanted to go fishing, I suggested they get a fishing rod.
Well, what is the current position in relation to readers? I mean, or rather, when did readers recommence?
Readers, they were always there, but they were never there for COVID. So if you had an industrial injury or industrial accident, then a red door would still be put in. But in relation to COVID, that guidance is still in place. So individuals who are contracting COVID in the workplace now will still not see a red door. And we're still not doing proper deep dives in relation to COVID outbreaks, in relation to PAGs. They still don't take place. And again, because we've still got the guidance in situ from the Health and Safety Executive, that hasn't changed either. So you're still not getting rid of us for COVID outbreaks.
We can turn to the next section of your witness statement, which deals with various aspects of the impact of the pandemic on staffing. And here there are a number of themes that you identify. The first arises from absence rates.
Yep.
Then a matter you've already touched on, which is deployment. So you've already talked about deployment problems and where people are working arising from PPE issues. And you go on to discuss deployment issues arising from absences. And you also discuss the cumulative impact of all of this on the mental health of staff in hospitals. So if we could just briefly talk about absence rates, in paragraph 32 of your statement, you say that, not surprisingly, absence rates increased dramatically. Yep. And what was the consequence of that for people who continued at work?
So the majority of our admin staff who could work from home were sent home with the bare essentials, and we'll come to that later. So in the hospitals, it was primarily your operational staff, your acute nursing staff, your labs, diagnostics, domestics, catering, portering. So that was the main workforce that was in a hospital setting. Majority of your admin staff had been sent home, apart from one or two small pockets, and therefore, because they were very much patient-facing, and very much because we were slow in relation to providing them with PPE, therefore the infection rates went up significantly. But at the same time, our infection rates in the community were going up significantly because we were getting more and more people into hospital, and therefore hospitals became really, really busy and probably overstretched with a reduction in the workforce to be able to provide those services. So when I say it was 160 to 180 staff per day, that was purely in acute settings. That wasn't including anybody else. Therefore, the result in that was wards were left short of staff. And the phrase that I heard constantly at that particular time was, we will shuffle staff around about the hospital. Now, we had an agreement and there was clear guidance that staff who worked in a red ward didn't work anywhere else. Staff who worked in the green ward, they were fine, but as soon as they went into that red ward, then they couldn't go back to the green wards. So the fact that we're shuffling staff around about wards just to cover gaps in service, we didn't have that detail of where staff were being sent to and where they had came from. Now, I asked for it on several occasions, and I made the point, I could tell you where staff had been on a Saturday night, because if there was an outbreak and it was related to a wedding or to a birthday party, I could tell which staff were there, but I couldn't tell you where they'd been Monday to Friday in the wards, because we didn't keep that level of detail, and that caused me a worry, because that way, and I go back to the PAGs, if we're doing proper PAGs and proper IMTs, we'd be able to know what staff was in what ward. The fact that we're shuffling them about purely to cover gaps in the services, we weren't recording it appropriately.
And the distinction between red zones and green zones, is that something to do with the care required?
So your red zone is your COVID zone.
Right, I see. Right.
Your green zone is non-COVID.
Right. Yes, so I mean, just to bottom that out, in paragraphs 34 and 35, you're indicating that staff were being moved around between the zones, irrespective of exposure to the virus.
Yep, it was who could cover it and who was available, and how we could spread that staff complement across the hospital settings.
And then in paragraph 36, you indicate that this further contributed to increases in anxiety.
Yeah, because staff who worked in a ward were fully aware of their patients and built up that rapport with patients, and they worked as a fairly close team within a ward. As soon as you start disrupting that and staff are coming in unknowing whether we're going to be in their own ward or in a separate ward or in a separate specialty, then staff became really stressed because they didn't know what their daily day was going to be involving, and therefore staff were coming to work with that level of anxiety about what's going to happen to me today and where am I going to be put. And it wasn't always comfortable for staff to be moved around about hospitals.
You do say, to be fair, in paragraph 54 of your statement that certainly NHS Scotland did respond to the mental health difficulties by started running wellbeing hubs.
Yes.
Yes. Can you remember when that began?
That began, I would say, probably early April, May 2020.
Right, so early on.
Very, very, very early on, and it was about creating spaces for staff to get out the ward and relax in an environment where it was fairly safe to do so, where they could get a cup of tea, cup of coffee, or whatever they needed. And it was about that chill out time, which was really important for staff. We also had quiet areas at the same time. These were drawn up fairly quickly in the early days of the pandemic within NHS here, and we then moved to develop that on a more permanent basis, and we've got wellbeing hubs in our three main hospitals.
Now, in paragraphs 42 and 44 of your statement, you discuss at some length issues around the testing of staff during the pandemic. And was there guidance on this matter? Yes,
so when we moved to daily testing of staff, or random testing of staff, whatever it was going to be, the guidance that came out is we would issue the LFTs, the lateral flow tests, and staff would undertake these at home to make sure they're negative before they come into the workplace. Where they became positive, then we'd wait to get PCR, and then they start their self-isolation. And that, the fact that it was a work-related activity, staff side and trade unions in general, made the point that therefore staff should be paid because that staff had to take time out of their private life to undertake the test, but also wait on the results, etc. Which to us seemed a reasonable position, plus it provided that security that you didn't have positive staff coming into the workplace. Some managers looked at that was an additional cost, and therefore rather than pay the additional cost to bring staff in at the beginning of their shift to undertake the LFTs, what that meant is you potentially bringing in positive staff. So you're saving a few pennies, but the reality is you could increase the spread of the virus, and therefore I always deemed that to be not very wise, because the reality is we created that guidance so that staff are testing at home rather than coming to the workplace positive. And again, it goes back to the money situation.
How long did that continue, that staff were to test at work rather than at home?
Not very long once we got wind of it, because we made the point that that was a useless exercise, because the whole purposes of staff testing at home was to ensure that we didn't bring it into the workplace or into a patient environment. So it probably did last 2 or 3 weeks, I'll be honest, but once we got wind of it and we knew it, then we got the guidance reaffirmed and sent back with clear notice that that was unacceptable practice.
Yes. Now, you also mention issues around vaccine hesitancy and the implications of compulsory vaccines, but again, the inquiry has heard quite a lot about that. I mean, is there anything specific you want to say about the implications of compulsory vaccines and vaccine hesitancy?
The vaccine hesitancy was, and again, because staff have got that level of knowledge about how long a vaccine takes to actually be developed, the effectiveness, and there was a bit of concern that it was so quick that we were unsure of what potential side effects were going to be, and therefore that was a slow burner to win the staff sides and the staff's confidence that the vaccines were the right place to go. From a staff side perspective, we always encouraged all our members to take the vaccine when it was offered, because it provided them with protection, the patients with protection, but also the families with protection. So we did win that argument with our own members, who then started taking the vaccine on a more regular basis. But there was that hesitancy at the very beginning. The other problem with the vaccines, of course, was when it first became available, who was eligible for the vaccines. And that, again, we created a two-tier workforce because it was patient-facing and close to patients. And our admin and clerical staff and people who are not in the wards weren't being afforded that same level of protection. Now, I've made the point and will continually make the point. Anybody who works within the health service is there to provide a service for the patient's journey from entering to exit. They've all got a role to play in a patient's recovery or a patient's treatment. And therefore, I don't see one being more important than the other, because the reality is, and I hear this constantly about frontline staff, the first person you meet when you get in the hospital is the receptionist, but they weren't getting the vaccine. So that argument that every single member of staff was equally as important as the other was one that we argued very strongly, and we won eventually, but it took a long while.
When you say a long time, I mean, by when was the argument resolved? And you?
Well, I couldn't tell you when it was resolved, but it probably take 3 or 4 weeks, yeah.
Right. Now, my Lord, if I could turn to one issue in Mr. Hope's evidence that is particularly significant. It concerns what he has to say about mental health nursing, and this is at paragraphs 59 to 60 of your statement. Now, if you could just briefly describe what you mean by mental health nursing.
So,
does the staff work in that area?
Staff who work in a mental health facility, and Ayrton it would be Midland View, which is our mental health facility. So the staff in there, and again, it's a different clientele, because the staff in there are probably a lot more physically fit than they will be in an acute setting, and therefore they're more transient within a mental health setting, and therefore, rather than being able to contain positive patients, the fact that they're transient and they're going about the hospital made it really, really challenging. And therefore, the infection rate among staff, because they're coming into contact with a lot more patients who aren't aware of the significance of the virus, and therefore that caused an increase in absences within the health setting as well. The other part was, and this isn't a criticism, but a lot of patients had difficulty understanding why their nurses, who they'd known for several years, suddenly had to start wearing masks to come in and treat them and speak to them, and that whole scenario. And therefore, I don't expect it would be unusual for staff, for the sake of their patients, to make that as comfortable as possible and do whatever they needed to do.
I mean, you say that some patients, in paragraph 59, so there's two issues. There's patients wearing PPE, and then there's patients with mental health conditions reacting to staff wearing PPE. in relation to patients wearing PPE.
No, patients, I think that's a mistake. Patients never wore PPE.
Right.
They weren't tolerating their carers wearing the PPE, and it became challenging within that particular setting because this was about individuals.
So we're focusing on their reaction to
Yes.
staff wearing PPE, so that's
Yeah.
something they weren't used to.
Yeah, absolutely.
No. And what was the response to that then from the staff?
Like I said, staff would probably do as much as they possibly can to make that process of getting the patients calm, getting the patients to understand the needs for why they were wearing masks. And I could probably say anecdotally that staff would probably remove their masks at some point, and again, it's to appease patients. But it wasn't through malice, it was through trying to provide the best care they can for their patients, which is understandable.
So one of the particular challenges in relation to mental health nursing then for the staff involved was the reaction of patients to wearing PPE. But another challenge you cover is that mental health patients are more mobile.
Yeah.
And you indicate that that means sometimes they move around within the hospital estate. They move around the country more?
No, just round about that particular facility. So if it's Woodland View, they'll be in corridors and going in and each other's rooms, and because that's what normally happened prior to the pandemic hitting.
Right.
And therefore, to change that routine for mental health patients is really, really challenging for the patients.
Yes.
And therefore, patient care dictated that we had to minimise the impact as much as possible. But they still had that freedom of movement.
In paragraph 60, however, you do relate one incident where a mental health patient was moved elsewhere, and that eventually led to, I think what you say is the only case of a staff member contracting COVID and dying.
Yeah.
Is that right? Can you say a bit more about that?
My understanding was the particular patient was moved up to a Glasgow facility for whatever reason that didn't work for the patient, and they were brought back into Ayrshire, but they were brought back in without the proper test being done, and by the time they got back into the workplace, that individual was COVID positive, and the member of staff who was treating that particular patient contracted COVID and sadly died sometime later. And again, it was about that lack of testing during the movements between Glasgow and Ayrshire.
Are there any differences in the impact of COVID on staff who worked in mental health nursing compared to other healthcare staff?
It would probably be a different impact, because the impact would be the impact what COVID did to their patients and the restrictions and how that affected their patients, and therefore that created that frustration or anxiety within the staff group. If you remove that and go back up to an acute setting, it was about that real devastating impact on individuals who were severely ill and dying as a result of COVID, and some of the impacts that had on staff in relation to their mental well-being, because they were in it on a daily basis, and then create that post-traumatic stress as a result of it. Mm-hmm. And I've spoken to several colleagues and staff members. While they were in that setting, their focus was very much on patient survival and patients' well-being. As soon as we started to come out of that particular part of the pandemic and that scenario, and we were less focused on severely ill patients, the scenes and the thoughts come flooding back to staff, and we saw an impact at a later date, because that's when staff had time to absorb what they'd actually lived through. Because at the time they were too focused on their patients and delivering that high level of care that they required.
And what about staff working conditions and attendance at work? Was there any difference there, or was that much the same?
So pre-pandemic, if we get breakdowns of staff absences and the cause of staff absences, and at that particular time, mental health related illnesses would equate to somewhere between 23-24% of all absences. Post-pandemic, or after the whatever wave, first, second wave it may have been, you saw that increase in mental health related illnesses, and now we're up at 34, 35, 36% of all absences. So staff are still reliving what they experienced during the pandemic, and they're still trying to understand it and deal with it, and it's really challenging. So part of that well-being structure that we spoke about earlier, we now have a direct line in to clinical psychologists, clinical psychiatrists for staff to go there and get the assistance they require, which I think is really, really important.
And were staff absences amongst those who were working in mental health nursing broadly the same or different?
Probably slightly less, but they were still very, very high, because we still had that scenario I spoke about earlier about shuffling staff around about hospitals to make sure we had proper cover.
Now, turning to another matter briefly, which is the impact on restrictions on visitation in hospitals. You deal with that in paragraphs 61 and 62 of your statement.
Yep.
I think what you're suggesting there is that dealing with relations and visitors was also disruptive and had an effect on working conditions and the mental health of healthcare staff.
Yeah, very much so, because initially there was no patient visiting. We then relaxed some of those guidances, and then it was appointments, visitation by appointments. It was only one at a time, and it was a particular time. And anybody coming into the hospital clearly had to wear the appropriate PPE or masks. And that's how it should have run naturally. But patients, loved ones, visitors, they are as anxious and stressed about their loved one being in that hospital, and therefore their anxiety levels were up, and not everybody was compliant with the guidance in relation to the masks. And staff rightly challenged individuals, but again, that could be a real confrontational point. But again, staff are looking for their own safety, but also the safety of the other patients. Visitors weren't always aware of that.
Now, you have a section in your statement about long COVID.
Yeah.
And again, this is a matter which the inquiry has heard about from other witnesses, including the fact that the impact of long COVID or the incidence of long COVID amongst healthcare staff is higher than in the general population. Is there anything specific you want to draw out from these paragraphs in your statement, which begin at 63 about long COVID?
I think the most important part about staff who then went on to develop long COVID, and I go back to those initial or the missing investigations, whether that be RID or whether that be PAGs, which were identified if that unfortunate individual contracted the virus in the workplace. Because once they then leave the organisation as a result of long COVID, they don't have that financial security that they should have had in relation to personal claims and industrial injuries benefit. That whole opportunity was missed. So if you do the numbers in Scotland, we're probably looking somewhere between 600 and 650 members of staff who had to leave work as a result of long COVID. I'm not naive enough to think every one of them contracted it in the workplace, but I am well aware that the majority probably did. But they're now leaving with that lack of financial security, or that financial safety net. And therefore their lives have changed forever. And I think they were at the expense of, let's save a few pounds at the beginning of this process.
You say in paragraph 63 of your statement that, in your view, at least for some in the NHS management, the employer, are less sympathetic, and you say that some people regard long COVID as the new sore back.
Yeah, and I've heard that expression in the workplace. Because, and again, because long COVID isn't one particular sign or symptom, and it's made up of a whole host of different problems that individuals can be left with. Some are more debilitating than others, but even the minor long COVID, so, and I'll take myself, as a result of COVID, I've got constant sinus infections, which is a problem for me. But if you take that into the workplace, it's like, oh, he's got long COVID again. And it's the reality of people are suffering as a result of, whether it be work or whether it be COVID, or whether it's that combination of contracting it in the workplace, but the employer's looking at it as a reason for staff being off. Not every employer and not every manager, but we've got the rogue ones who do.
Before we come to lessons to be learned, there is one matter I would like to ask you about, although chronologically I suppose it goes back to the beginning of the pandemic, which is the section of your statement where you're talking about working from home.
Yeah.
And this is at paragraphs 70 to 72 72 of your, well, it's a little more than that, sorry, 70 to 74 of your statement. And this concerns staff who were able to work at home, of course, so that would mainly be administrative staff, yes. And what you say in paragraph 71 is people, well, they were sent home to work at home basically with their laptop. And there was no other support. Staff were sent home with a laptop and phone, and that was it, is what you say in paragraph 71. And there was no, and that led, of course, if they were working at home, for example, to sitting at desks, and you give other examples, including, I think you say, people sitting at ironing boards and so on. And you indicate that there were musculoskeletal issues with people's neck and back because sitting for long periods in inappropriate chairs. I mean, is it your evidence that, given the responsibilities that you're aware of, support such as chairs and proper chairs were not provided?
Absolutely not. People were literally sent home with a laptop and a phone and asked to get on it. And therefore to make their own arrangements within the home. And the reference to the ironing board and sitting on the sofa is a factual one. There was a member of staff did that for the best part of 2 years, who then developed muscular back problems, neck, shoulder problems. The emphasis should have been on the employer to undertake a proper risk assessment to see what that individual needed to work at home, a proper desk, a proper workspace, proper screens, DSUs. That whole risk assessment about slip, trips and falls never actually took place and still hasn't took place. As a result of staff being sent home to work, we've now created a home work and flexible work location policy, which dictates quite clearly that if an employer is asking individuals to work from home, then they have to provide them with the proper equipment, desks, proper chairs, proper video screens, etc., so that the individual has got a proper workspace.
And what if someone had a chair at work, though, for example, if they had a therapeutic chair at work before the pandemic? I mean, would they not take it home or be provided with it?
Not everybody did.
No.
The majority still haven't, to be honest. And I only know that from the team that I manage, that the majority of them are still using a work laptop and a phone.
So they didn't have the chair, they might have had it at work, for example.
Because everybody who works in their own office has got their own chairs and their own screens, etc.
I mean, are you aware of an increasing prevalence of these repetitive strain injuries or bad?
Yeah, you see it, and again, you go back to
so
that absence reporting that the organisation undertakes. You see that increase in the musculoskeletal problems on a recurring basis, and again, it's that referral into occupational health, looking for physiotherapy treatments, etc., or occupational therapy treatments and how to conduct it, etc. So you have seen an increase, and I think we will continue to see that increase until we bottom out proper workspaces for staff in their own homes that are secure and safe. The other issue was when we sent staff home without that proper risk assessment, they often suffered from that seclusion, that they didn't have that interaction with their colleagues, and that again caused their own individuals to feel that stress and anxiety because of isolation syndrome, and that's still something that we are working through, and again through our wellbeing hubs we are tackling it, but it's a major issue.
Well, thank you, Mr. Hope. The last part of your statement is a substantial one about lessons to be learned from the pandemic in light of your experiences. And if you were to identify 2 lessons to be learned, what might you say they were?
The first one has to be applied not just through a pandemic but at everyday life, that unless you can ensure your staff's safety, you will never be able to provide patient safety, because they're both in the same environment, and unless they're in balance, then one of the two are going to be at risk. And therefore, by failing to provide staff with that initial PPE and again I go back to the investigations outbreaks, we've never put staff in a safe place, and we need to go back and reflect on that. And going forward, we need to make sure that staff safety is our #1 priority, because without that, you'll never ensure patient safety. So I think that's the first learning. The other one, and I keep coming back to it, is we knew COVID was coming because we'd seen it for 3 months on our TV sets every night. We still weren't prepared. So that preparation for what's coming over the horizon is real. And rather than waiting until it gets here and we look like rabbits in the headlights, we need to have that preparation and plans in place for an outbreak, whether it be COVID or flu or whatever, because we know there's going to be another one. Unless we take the lessons learned from here and make sure we're ready and we're prepared and we've got a plan, then I think we'll always get into the same pickle. I remember asking a senior clinician before the first case came to Scotland about what our COVID plans were and how we're going to deal with it. And the response was, we don't need a plan, we've got a flu pandemic plan, that will do, and clearly it didn't. So that glib answer to me was really, really damning, because the reality is we knew what was coming because we'd seen it in North Italy, and we were still not prepared. And therefore we have to take every opportunity to provide safety for staff and patients in a hospital setting and a community setting, because it's really important.
Well, Mr Hope, your witness statement as a whole and your evidence today will stand together as your evidence to the inquiry. I mean, is there anything else you would like to say in conclusion?
No, I don't think so. I think we've covered the main points. Thank you.
Well, I'm very grateful to you for your statement and your evidence today, and my lord, that completes Mr Hope's evidence.
Thank you. Thank you, Mr Hope.
Thank you, Mother.
Very good. Tomorrow morning. Thank you.